Well, thank you very much. It's nice to be here, nice to be invited with the Hall of Fame, and lovely to see that we've got a mixture of people in the audience. And thanks for these introductions, Sanjay. So I've got almost a lifetime interest in liver disease, and my fascination goes into liver disease really from inspiration, both on a personal level and on a professional level. And it's been really 20 years of that journey. So I'm pleased to really just give you some pearls of wisdom from my experience both in the UK and United States. I thought just talk to you about this actually relatively common condition, but which goes under-recognized. And it's important that you know about that in your practice, because some of hemochromatosis may well be either hidden in your practice or may masquerade as other conditions. So in the topic today, we really have a typical case study. Then we'll talk about iron balances or imbalances or homeostasis in iron. And then we'll touch on or discuss in some detail the condition of hemochromatosis and the multi-system nature of the condition. We'll talk about the nuances in emerging molecules, hepcidin, to say the least. And then we'll touch on the medical management and then your practice, how you manage the condition, or whether there are any dilemmas in your management. And then we'll touch on non-HFE condition, previously and then current knowledge. And then we'll sum up and then open the floor up to questions about your everyday practice and how I can help you actually in dispelling some of the myths about iron overload. So this is a typical kind of case that we would see. This is an Irish gentleman, 60-year-old male, who's got a couple of months history of fatigue and joint pain. Does drink 2 beers a day. He's got a brother with diabetes mellitus type 2. And on physical examination, he's got a 1 centimeter hepatomegaly, and on top of that, there's some tender metacarpal phalangeal joints, and he's got a couple of tattoos. So really, he's got some, even without an HFA history, you could say, look, you'd have to exclude some typical chronic liver conditions, they being either non-alcoholic fatty liver or even hepatitis B and hepatitis C. So these would be a typical, liver test that we would have done on this patient. And as you can see, there's some mild transaminase with normal bilirubin and a normal fasting glucose. So it's not certainly he hasn't got diabetes. But as you can see, after he stops drinking, his liver tests regrettably remain unchanged. So there is a problem, and it's certainly not hepatitis or autoimmune. So, what would you do next? Well, really, the kind of thing that we would do next would really be, we mustn't forget iron. And when we did his iron studies, we found that he's got a modestly elevated ferritin at 640 and a raised transferrin saturation of 60%. And the cutoff that we have in the UK is around 45%. So he has got evidence of iron overload. Okay. So what is the diagnosis? Well, clearly the diagnosis is hemochromatosis, and so that's a typical case one would encounter. And clearly, as he's symptomatic, he would need treatment. One of the reasons to show you this is because we're often posed with the problem. Sometimes we may even ignore as clinicians, arthropathy, shortness of breath, etc. So these are things just to bear in mind, that these presentations, don't ignore the multi-system effects of liver disease, arthropathy, heart disease, sexual dysfunction. These manifestations in a busy liver clinic, can go undiagnosed. When one is so obsessed with, investigations, beware that you should try in your practice take some brief histories related to these, and so please don't ignore them. And so, we've talked about that. So that was a symptomatic hemochromatosis patient. Don't forget the asymptomatic patients. Quite often we're asked to do a blanket set of liver tests, and we find and we uncover hemochromatosis this way, and it's the more common way of presentation, where when we discover asymptomatic patients, when we probe a little bit more deeply, we find actually they have got degree of fatigue and they have got a family history or first degree in particular relative who's got genetic condition, and particularly hemochromatosis. So, you know, when you leave today from this talk, just be aware of the extra things to ask your patients, particularly family history. And this is something, particularly if your lab breaks down, but you only have the serum iron and the TIBC. This is one way to calculate your transferrin saturation. So don't forget, the serum iron divided by the TIBC times 100% is a marker of the transferrin saturation. And you must be aware that the transferrin saturation, you know, does vary throughout the day, and as well as with a fasting or a non-fasting state. So we usually do a transferrin saturation, if possible, during the morning, and if possible during fasted state, because as with a meal, it can go up. And the levels that we're talking about that are significant, particularly for men, is over 300 micrograms. And then in women, premenopause is 200, and in postmenopause, 300. And of course, if a liver biopsy is done, then a ferritin over 1,000, you know, is clearly important. And a biopsy could be important to assess level of damage, particularly with coexisting disease such as non-alcoholic fatty liver. So hopefully that's understood. And of course, there's genetic testing, which we'll come on to. So actually, when we do genetic testing for patients, index patient with hereditary hemochromatosis, you know, beware that its clinical presentation is clearly very important. It's the first degree relatives of known case, you know, that needs to be considered, and it's worth considering, particularly when you've got liver biopsy that's suggestive of iron overload, when you didn't know that it was going to suggest that. So in other words, when you find iron overload, perhaps as an unexpected finding, so beware that patient will require a formal genetic testing. So the value of genetic testing is clearly very important, A, to confirm the diagnosis, but also to make sure that the other family members don't get left out. So it's very important to screen siblings or first degree relatives, okay, which will then influence the further management of that patient. And of course, there are other things that we mustn't forget. So environmental modifications are very important for that, then, of that patient where the diagnosis is made. So for example, dietary, alcohol, hepatitis A and B immunization. So our patient, Seamus, you know, decides to have a genetic testing, and he's found to have the homozygote C282Y condition, which is the more common presentation, and he goes on a standard phlebotomy venesection program. And then actually following that management, then we decide really to look at his family history. And I don't know whether you're familiar with these type of diagrams, but as you can see, Seamus, you know, in the middle here, he's here. And you can see then his other, interesting, his brother, and then his sister. His brother has got diabetes. Rather, his brother has got diabetes. He was age 55, and his sister age 64. So you can see that you know, they may well need to get genetic testing. And in fact, it's interesting. You know, his father died of liver cancer. So again, you know, these are things that would be risk factors, or maybe as a consequence of hemochromatosis. In fact, his father actually died from hemochromatosis with secondary liver cancer, HFE-related HCC. So you can see here the presentation, certainly in his first degree siblings, were arthritis and diabetes. So this is the power of these type of, you know, family history, exploring very carefully into the family. So then the next question then comes, well, if I've got the gene, then I'm going to get the disease, doctor. Well, not necessarily. And this is a very this statement is very important in the concept in genetics, because then it brings the idea of penetrance of genes. So the proportion of individuals, the mutation causing a particular disorder who exhibit clinical symptoms of that disorder. So it means that every time you have the gene, it doesn't mean you're necessarily going to get the phenotype of that gene. Yeah. So there is this concept you may have heard of called incomplete penetrance, of which the HFE gene is a par example of that. So the C2825 gene is actually a low penetrance gene. So it doesn't always come out in terms of its phenotype. So that's the genetic side of things complete. And now, hopefully, if you've understood that, new things that you can bring to your practice, new ways of thinking, not forgetting to consider family testing as an important aspect of whenever you find HFE genetic screening in the index patient. I'm now going to move on to iron exchange and iron hemostasis, and we know that certainly iron can move around actually from the reticular endothelial system to the erythron, to the RBC and the precursor in the bone marrow, and within those two sanctuary sites, the transferrin and the red cell as a way of moving iron from one place to another. So iron balance in hemochromatosis is really important, because we know that iron hemostasis is actually maintained at the level of the duodenal enterocyte. So it all happens at the duodenal enterocyte, and iron absorption is controlled by specific regulators. And these are, for example, these are iron stores, the erythroid activity, hypoxia, inflammation. These are all factors, amongst others, that would control iron absorption. And of course, in hemochromatosis, the iron balance breaks down because there's increase of iron amount, which is withdrawal from the diet. So the capacity to regulate iron excretion is limited, which then influences the course of hemochromatosis. And as you can see, as a par excellence here, you can see that there's a combination of different environments. You can see that the iron is taken up from the duodenum, and then it gets shuttled into the liver. And then the other influences then are the red cells and the macrophages. And between them, there's a milieu between the systemic iron hemostasis and the excess iron, okay? There's a kind of homeostatic mechanism between these kind of four areas. And this is just another example of that. So really, we've got this concept of iron homeostasis, where there's a precision between the iron in and the iron out. And in total, the 15 milligrams of dietary iron is available in a balanced diet, from combination of what comes in to what goes out. And of course, what goes out is, for example, stool, skin, blood, urine, to what comes in. It's really primarily from the duodenum. So this is a couple of points which I think is important to mention. So I did a little review actually from last year, and really I found some reviews on iron hemostasis. And as you can see, the mechanism for control of iron excretion is really ultimately and fundamentally really then dependent on iron absorption. Okay, and so just summarize that it all depends on iron absorption. Okay, so whatever happens in hemochromatosis, it depends on what occurs at the absorption level rather than excretion level. So moving now on to hemochromatosis itself. So before 1996, the whole scenery was absolutely static. We knew that familial iron overload is HLA linked. We know, or did know, that the condition is predominantly male, usually presenting around 40 to 60 years. And we know that there's a problem related to the transport and storage of iron, which results in increased iron stores, liver damage, resulting in cirrhosis, and the treatment is phlebotomy. It's well recognized. there is a form of hemochromatosis, which is particularly present in juveniles, which is juvenile HFE. And this has got an equal sex distribution, and it's got a particular form of tissue damage, which occurs in different phenotypes. So for example, there's more of a problem related to cardiac, pituitary, pancreas, as well as the liver. So these are extra liver type manifestations, which is important to recognize in that population. This is important, this slide, because it gives you a variation of the haplotype assignment in hemochromatosis. So you have obviously the disease homozygote, then there's the concept of heterozygote and carriers, which is important to distinguish. And then the mutations, as we know, we all recognize the common mutation, the C282Y, which is essentially the tyrosine, which replaces the cysteine at position 282. Then there is the histidine aspect, which replaces the aspartic acid at position 63. And that is the H63D mutation. Can you just excuse me for a second? Would you mind? Excuse me for a second. Sorry about that. Hopefully that gives you a pause anyway. So as you can see, there are variations of the genetic makeup of this from C282Y to H63, but there are these concepts that you need to understand, which is homozygous C285, then there's a heterozygote for C282Y, and then there's the compound heterozygote, and then rarely there are different genotypes of the HD and the DD genotypes, which can occur clinically, and it's important that you're aware of that. Okay. So we all know that following a mutation in HFE, this causes an increase in serum iron, which then leads to an elevated transferrin saturation, which then leads to tissue iron deposition, which that itself can lead to elevated serum iron. And then there, of course, it's something that we need to avoid is the organ damage, particularly liver. And of course, and I've outlined to you, there's damage related to pancreas, heart, pituitary, and joint dysfunction. Okay. And so from the multi-system nature of the disease, this is something that, you ought to again be aware of your holistic nature of your practice. It's not just about liver, and it's not just about avoiding cirrhosis and liver cancer, of course. Beware of the diabetic patient, particularly the type 1s, premature type 1 diabetes. Why do people get that? Beware of diabetes and HFE. Beware also people or young men, who get hypogonadism. Beware also those patients who get unexplained cardiomyopathy. And of course, more commonly, people who can get arthralgia, particularly at the very destructive form of arthritis, or indeed those patients, but it can be very difficult, particularly in Asian looking skin, but when you've got, even further increased deposition of ferritin in the skin, and that can lead to characteristic pigmentation, particularly around the flexure surfaces. So beware of those manifestations. And these are the common features that you would ordinarily see in your practice of the common presentations. Again, as I've said, tiredness, lethargy, arthralgia, abnormal LFTs, but the more serious ones are the ones I've outlined on the right. Obviously diabetes, liver disease as well, and the destructive non-reversible nature of the arthritis and the cardiac dysfunction. Incidentally, the cardiac dysfunction can be a diastolic dysfunction, and in some cases it can be dilated cardiomyopathies. So just be aware of those type of nuances. Now, we're trying to move away from liver biopsy when it comes to HFE management, but if you were to do liver biopsy, particularly if you weren't sure in your diagnostic differential diagnosis, if you were to do liver biopsy, you would ask your pathologist that you'd want to use a trichome Masson's or a Prussian blue stain, all right? And if there were to be iron load, particularly from HFE, The iron deposition is usually in periportal pattern. It's usually mid-zonal and centrilobular. Occasionally, there's biliary epithelium deposition of iron. What's really important, particularly in genetic hemochromatosis from HFE, is that most of the iron is not in the Kupffer cells, usually cytoplasmic, all right? So when you get iron deposition from a liver biopsy, then, and you have to work backwards, and particularly if you haven't got HFE as a diagnosis at that stage, you need to make sure that you've the genotype on that patient and make sure you've excluded C282Y or H63 as the common gene mutations. And like I said, if you were to have done the biopsy, and this is kind of what you'd see, as you may know, you may see the Prussian blue staining in cytoplasm. You can see that it's quite distinct for in a normal H&E staining. And then moving on, you can see that again, the Prussian blue, again, the cytoplasmic staining is quite pronounced, actually. And there's the beginning of nodule formation. As you can see, it's more pronounced here. So you can see cirrhotic nodules coming there on the background of HFE, typical genetic hemochromatosis biopsies. Okay, so the HFE gene was only cloned in 1996, and like I said, everything happened after 1996. And the gene was localized to chromosome 6. There is an MHC class 1 association. The most common genetic mutation is C282Y. And certainly in the West, this is restricted to Caucasian population with the highest frequency in Celts, but it is recognized certainly in other parts of the world, particularly in India, Pakistan, and other areas where there may be a juvenile version. And I'll be interested to hear about your views at the end of the lecture. So in Western countries, particularly Europe, as you can see, this is the distribution of the Y allele in Europe. As you can see, there's enormous focal distribution, particularly as you can see in Ireland, in Scotland, and in the east coast of England and in the Western England. So as you can see, there's huge distribution and focal distribution of that. And then as you can see in the Scandinavian countries, it's rife, very common to have the Y allele. So it's a common condition. And it's certainly, it was first described certainly as far back as Celtic and Viking origin. It's almost 4000 BC, possibly around that time. And as you can see, the further east you go, the less it gets. Okay. So the HFE gene, as I've said, it's pivotally involved in the absorption of dietary iron. And as I've said, I've outlined to you, the gene is highly, can be highly penetrant. The prevalence of the gene is 1 in 200, with 1 in 10 of carrier. Very common condition. So do all C282Y homozygotes have an iron overload? Well, as you can see from the Cardiff study, where they took 10,000 blood donors, this found that there was a prevalence of 8.9% chromosome mutation, and the homozygote frequency distribution was as common as 1 in 30, which equates to approximately 22,000 homozygotes, in Cardiff and Wales. And then in Jersey, we found that the chromosome prevalence was 8.3%, all right, which equates to around 1 in 145. Okay, so as you can see, it's a common condition. And so the penetrance, as I said, though, unfortunately or fortunately, does vary. So not everyone will get the condition, but we have to be aware of it. So what do we mean by penetrance? Well, what we mean, certainly in the phenotypic penetrance, we mean that certainly biochemically, there is a raised serum iron ferritin, and as we said, probably 50 to 75% in most cases. There's certainly an increase in iron stores, which is usually over 5 grams, and this can be treated by venesection or phlebotomy. And there's certainly evidence of marked iron stores, which manifests as tissue damage. All right. Then again, this is a slide that just demonstrates you the importance of alcohol and dietary, and the fact that alcohol can actually be a cofactor in accelerated liver disease, particularly with cirrhosis in people who drink alcohol, as well as people who don't drink alcohol. So in people who've got non-alcoholic fatty liver, the HFE can accelerate in terms of its liver damage. So beware of those coexisting conditions. And we're now going to move on to the pathophysiology of iron. And as you can see that, as I've alluded to, that iron is absorbed through the duodenum. Then there's a pathway which is critical that you need to understand, where it gets converted from Fe3 plus to Fe2 plus. All right, it gets shuttled through the enterocyte, all right, through into the cytoplasm, all right, and then into the bloodstream. The way it gets into the bloodstream is there's a critical protein called ferroprotein, all right, ferroportin rather, and this then converts Fe2 plus to Fe3 plus. So you need to understand that the ferroportin protein is like a gatekeeper to the bloodstream, right, from the enterocyte. So more of that to come in the future. All right, I'll explain that in the next few slides. So hepcidin, as I mentioned to you right at the beginning, hepcidin is a critical factor, because it's a critical protein which regulates the serum iron efflux by binding to that ferroprotein, okay, and inducing that internalization, which I've just outlined to you. And ultimately, it goes into a protein, but it's actually initially it's a peptide hormone, which is synthesized in the liver, and it controls the systemic iron availability and adjusts this to its tissue requirements. So it's almost like the hormone which controls iron in your body, and it's controlled mainly at the transcription level, and this control is maintained by your iron status, by the level of hypoxia, by the level of erythropoietic activity, and the level of inflammation. Okay, so, and more of that to come in a second. Then, in addition to ferroportin and hepcidin, there are also three proteins which you need to appreciate, and they are HAMP, the HFE, and the TFAR2 protein genes, right? And these are all related at the hepatocyte level. A mutation in all these three proteins can lead to hemochromatosis, okay? So as you can see, this diagram, this schematic diagram kind of summarizes that. So you can see the hepcidin, which is then produced from the liver, then increased expression of hepcidin will control the amount of then iron activity and internalization within the enterocyte, which then controls the amount of ferritin, which is then produced from the enterocyte, which then indirectly and directly then leads to the three proteins which I mentioned, which are related to HFE, TFR2, and the HJV, okay, which then indirectly and directly then relates to the amount of iron that's transported from the macrophage. Okay, so this is a very interesting and a summarized schematic diagram, which summarizes the stimuli which modify liver hepcidin expression. Okay, so as you can see, so the amount of iron that you take in, either high iron or low iron, growth factors, then anabolic cell growth and proliferation of these responsive nutrients. See, these are all factors which relate to the transcription then indirectly and directly then of hepcidin. Okay. So I'm going to move on now then to the frequency and the expression then of C282Y and the management of hemochromatosis. So as you can see, the condition is obviously common in Australia and France. I've outlined to you, obviously in the UK, and you know and less common or lesser common in some of the European countries compared to Australia and France. This is an important slide because it underlies the typical C2A2I type HFE genetic hemochromatosis, which is used to be referred as type 1 autosomal recessive. But now, since 1996, we've identified several other non-HFE hemochromatosis type conditions, all right? And these are all related to the protein and the genes which I've mentioned to you. So related to, this is why I mentioned these proteins and genes, TFR2, the ferropotin, the HAMP, and the HAV, and the BMP6. So these are all conditions which are important because deficiencies in these can relate to iron overload. All right. So obviously, if you have HFE, the typical way that you and I know it, that would be typically so-called type 1, right? Now, these classifications, you know, are evolving as we speak. So this is a slightly older type of classification, right? But it's the kind of thing that most people are using at the moment. But as you can appreciate, really just from this slide, that there are variations in the inheritance from autosomal recessive to autosomal dominant, you know, to these non-HFE type conditions. Okay. So another reason to show that is that you can see that since 1996 we've cloned these new genes, you know, of TFR2 and the hemojuvelin. So this is a slide just to illustrate to you that these are new genes which have been cloned and which allows them to characterize and to understand iron overload in more detail. This is interesting. So if you were to do a liver biopsy on some of these conditions which I've outlined to you, you know, the type 2, type 3, type 4, and type 5, you would find that there are variations in iron overload in these conditions. So typically, so for example, if you look at slide D, you would see that, for example, in ferroportin disease, you would see that the iron overload, you know, gets deposited in just the Kupffer cells, hardly anywhere else but just the Kupffer cell. And that's the reason to show this slide. Sometimes it comes up as a board question as well, but this is important to elucidate and just to understand. So remember, Kupffer cells, iron, ferroportin. And then, you know, after 2006, these are the things that we've you know, gone on to understand, that obviously, you know, hemochromatosis has, as I've outlined to you, it's a familial condition. There's marked increase in liver iron stores. There's obviously tissue damage, and the treatment can be from venesection. So now in 2022, we know that when you walk out this room, you need to get an understanding that there are multiple genes, and these are the kind of 4 or 5 genes that you know, well recognized, the TFR2, etc. And nearly all forms of the hemochromatosis which I've described to you now are now, majority of cases are related to the hepcidin deficiency. Okay. And so they all lead to, you know, variations in the penetrance, as I've outlined to you. Okay. This is an important slide. So in your practice, you may wish to understand. So if you're faced with a patient who's, say, 50 plus, you know, it's very likely that patient is going to have the standard HFE gene. Okay. But if you're faced with younger population, particularly, you know, in adolescents, you know, beware of these other genetic, you know, newly characterized HFE conditions. So, you know, beware of the younger population who gets kind of early cardiomyopathy or heart-related type problems. Beware of the younger population, you know, who get endocrine type deficiencies. So beware of these conditions. And these are all related, let's say, on the whole, related to the type of hepcidin deficiency, lack of or variations of hepcidin within the body. So we're now going to come on to the medical management of hemochromatosis. So the goal of medical management is to detect patients before symptoms of iron overload. And we would ordinarily take blood off weekly or sometimes twice weekly, so that after a course of 10 venous sections, we would try and get the ferritin down to levels of 25 to 50. So that patients may even require venous sections every 3-4 months in the maintenance phase. Then, of course, we would try and educate patients about dietary recommendations, what they can and what they can't eat, and I'll come on to that. And this slide just shows you that the management of carriers. So, for example, if you are C2A2Y heterozygote and you've got some indirect markers of iron overload with abnormal liver enzymes or clinical evidence of liver disease, and that's where liver biopsy might be useful. Then, if you're heterozygote again but have got iron overload, then beware of rarer mutations which may coexist with the C2A2Y heterozygote. So beware of those rarer forms. They are indeed very rare, but just be aware of them, okay? And then, of course, beware of the H63 heterozygote and the C2A2Y together. These are carriers, and they're not necessarily a risk of iron overload. And then dietary recommendation that you'd want to recommend to your patients is really to avoid vitamin C, iron supplements, of course, excessive alcohol, and eating raw shellfish. And this is a slide which just tells you the response to phlebotomy. Why is it? What's the clinical indication, as well as to getting the transferrin saturation down? You want to make patients feel better about themselves. So, but eventually the idea is to reduce tissue iron stores, improve energy levels, obviously to improve survival, particularly if they're diagnosed with cirrhosis and diabetes, to improve cardiac dysfunction, skin pigmentation, and hopefully to reverse hepatic fibrosis in a third of cases, sometimes even to improve diabetic control. Sometimes, particularly if patients have got cirrhosis or testicular atrophy, regrettably, these can't be reversed. And this is a slide just tells you about the non-venesection type of treatments. And we're all aware of desferrioxamine. Well, you just need to be aware it's very important that desferrioxamine as a subcut infusion, progressively can cause allergy type responses. There's also GI symptoms, which are untoward effects, and they can be heart effects, so tachycardia or even low platelets. There are new kids on the block, which are deferriprine and deferrisrox, which are convenient, and these are emerging forms of therapy, which are oral chelating agents, and watch this space. And there'll be more of that, and certainly in phase 3 clinical trials, which are coming up to characterize those better in practice. And this is something that you just need to appreciate, that ultimately, I've outlined to you the value of liver biopsy, but nowadays we're all using fiber scanning. So I would suggest, if at all possible, if you can try and get away with a fiber scan and MR technology, it's better to do that to grade and stage patients rather than liver biopsy. And of course, there's venesection, as we've said. And ultimately, you'd like to get the ferritin down to less than 1,000, less than 100, and ideally to 1525 type levels. This is an important slide, which just tells you the pathological variations in the non-HFE related type genes. So just be aware of the rare HFE related hemochromatosis, the non-HFE related hemochromatosis, and the diagenic hemochromatosis type genes, which I've outlined to you. This is the type 4 and the type 5, which I mentioned. And then this is something that I took from Gastroenterology, which came out in 2010. It just underlies to you the ferroportin disease. Don't forget the ferroportin disease, because sometimes that can manifest as iron overload, most likely, or sometimes it can be non-iron overload. All right, but it just this slide underlies the importance of pathogenic mutations. And so this is quite common in our practice, the problem of raised iron ferritin level with our iron overload. And certainly 90% of patients with raised iron encountered in routine practice don't have iron overload, and may be difficult to investigate, but just to say that certainly in practice, it could be elements like race and ethnicity which may affect iron metabolism. And certainly from the AIR study from 2005, this showed that this was a possibility, apparently in healthy individuals, of that variation in ferritin levels in these individuals. That said, we can still get caught out in the rarer forms of mutations for HFE. So that's important. Just back to ferroportin disease, there are two types of ferroportin disease, one with excess copper, another one with less copper. But just to say that just be aware of the two types of ferroportin disease, where you can have low transferrin saturation, where the iron resides mainly in the reticular endothelial system with iron deposition in the liver. Then there's high transferrin saturation, where you've got then iron mainly in the parenchymal iron deposition. So there are two types. And then the mechanisms of raised iron, there are in broad principles, it could be either related to excess synthesis or secretion. So for example, conditions, chronic alcohol abuse, malignancy, particularly lung, that can give you raised ferritin. Then a raised ferritin can be as a result of injured cells. So for example, in NASH or viral hepatitis or ischemic necrosis, there's condition where there can be an acute insult that can give you raised ferritin. And then there's condition due to iron overload itself. So the HFE and the non-HFE hemochromatosis, which I've mentioned. And so just the last few slides, how do we prove that there is no iron overload? We've talked about the blood testing, so transferrin saturation. Then there's obviously, it depends on your friendly radiologist. There's increasing moves depending on the type of MR scanning that you have to look at quantitative MRI scanning, and that's becoming more widely available. It probably will replace liver biopsy in the future. Sometimes we do need to liver biopsy for the reasons I mentioned. There's also quantitative phlebotomy as a way of then proving or disproving iron overload. And then probably more commonly is the watch and wait strategy sometimes. There is sometimes less is more in medicine. This is interesting. So the relationship between liver iron concentration and transferrin saturation, it just shows that there's correlation between transferrin. So the higher the transferrin saturation, it means that the more chances of iron being concentrated in the liver. All right, so there's a positive correlation between the two. And this is just a summary of the assessment tools that we have in someone with normal transferrin saturation. Of course, there's the liver screen, then there's the standard liver enzyme. Beware of the body mass index, of course, and obviously alcohol. And this slide is taken from Hepatology from 2017, shows the importance of not bloodletting patients who've got non-alcoholic fatty liver. And it just confirms that you shouldn't necessarily do venesection on patients who've got non-alcoholic fatty liver and you've got raised ferritin. So it just underlies that. And these are just last few slides on guidance from the British Journal of Hematology on the types of raised ferritin, just in broad principle. As I've said to you, when you think about a patient with raised ferritin, think about it in terms of, is it due to iron accumulation from increased ferritin synthesis? Is it due to other co-conditions like malignancies and so forth, or inflammatory conditions, or is it due to cellular damage? For example, from fatty liver or alcohol. And again, just a penultimate slide. This just reinforces to you that ultimately the aim is, particularly if you're faced with someone with a very high transferrin saturation and raised ferritin, that needs to be brought down quickly if possible. And this last penultimate slide just reinforces the need for next generation sequencing. And the next generation sequencing has transformed the way we think about HFE. And as you can see through that, we have identified the various types, type 1 to type 5 of hemochromatosis, and through that, it's very likely we may encounter more cases of HFE or non-HFE in different populations, and through that, actually, we've uncovered non-HFE related populations in the non-Caucasian populations, particularly in South Asia and the non-Finnish populations and non-European populations and African populations. So in summary, ladies and gentlemen, I've outlined to you the concept of HFE, iron imbalance or balance, multi-system nature of the disease, the importance of hepcidin, medical management of HFE and non-HFE, and the development of hemochromatosis from previous to 1996 to now. And hopefully you've had a taste of what's been there, what's to come, and hopefully I can help you in your day-to-day practice. So thank you very much.